In this next portion of our learning, we'll be expanding our conversation to explore how culture intersects with childbirth and why cultural competence is essential for safe, respectful midwifery practice. Culture shapes identity, communication, decision-making, and, crucially, how people interpret pregnancy, birth, and the postpartum period. Because of this, culturally competent care is not optional. It's a core feature of ethical, effective midwifery. Culture influences expectations of pregnancy and birth, decisions regarding pain, interventions, and postpartum practices, communication patterns, who speaks, when, and to whom, roles of family, elders, and partners, beliefs around vulnerability, modesty, and bodily exposure. When cultural needs are ignored, patients feel unseen, unheard, and sometimes unsafe. When acknowledged and integrated, care feels personalized, respectful, and meaningful. Lack of cultural competence has consequences. When midwives do not understand or integrate cultural needs, the outcome is predictable: loss of trust, miscommunication, reduced satisfaction, and avoidance of care. This kind of failure is not benign. It directly affects health equity, safety, and engagement. A well-cited takeaway in healthcare ethics is clear. A culturally misaligned system is not simply inconvenient, it reinforces inequity and harms relationships. In contrast, when cultural competence is present, several benefits emerge. Access. Individuals are more likely to seek and continue care. Trust. Families experience care as respectful and aligned with values. Accuracy. Better communication improves clinical understanding and diagnosis. Outcomes. Strong relationships enhance adherence and support informed decision-making. Competence is not perfection. It is about curiosity, humility, and willingness to adjust practice. There are 5 components of cultural competence. 1. Cultural encounters. Real-world cross-cultural interaction, not just theory. Examples include learning directly from community engagement and observing cultural rituals respectfully rather than relying solely on assumptions. Key point: experience builds competence. 2. Cultural desire. This refers to motivation, not obligation. It is the difference between "I have to understand this" and "I want to understand this." Cultural desire is rooted in respect and authentic interest. 3. Cultural awareness. This involves turning the lens inward and examining your own assumptions, beliefs, and biases. It is the foundation of reflexive practice. 4. Cultural knowledge. This includes learning about cultural practices, norms, health beliefs, and explanatory frameworks for illness and birth. 5. Cultural skills. This is where theory becomes practice: effective communication, accurate cultural assessments, and behavior that demonstrates respect. When competence is present, research repeatedly demonstrates 3 outcomes. 1. Culturally competent practitioner. Confident professional communication and respectful clinical behavior. 2. Improved quality of care. Better decision-making, reduced misunderstandings, and shared agency. 3. Improved health outcomes. Higher adherence, improved comfort, and better physical and emotional well-being. Now let's translate the theory into practice. We will walk through 5 key strategies. Strategy 1. Reflexivity. Reflexivity is critical self-examination. Before entering care interactions, pause and ask, what biases or assumptions am I bringing into this encounter? Reflexivity prevents unconscious stereotyping from shaping care. Strategy 2. Communication. Communication goes beyond language. Use professional interpreters, not children. Learn key phrases in the local community languages. Use the LEARN model. Listen to patient perspectives, explain your understanding, acknowledge cultural differences, recommend a plan, negotiate agreement. Strategy 3. Education. Education must be layered and ongoing. Curriculum, include cultural and linguistic diversity in formal learning. Service learning, engage with communities. Workshops, provide hands-on training in cross-cultural communication. Competency requires practice, not just theory. Strategy 4. Environmental adaptation. Care environments should reflect and support cultural diversity. Examples include allowing cultural foods during labor or postpartum, supporting extended family involvement where appropriate, providing modesty-aligned options, such as adjustable gowns or flexible birthing positions. A physically respectful environment communicates safety and belonging. There is a risk worth naming: performative competence. This occurs when knowledge exists but is not practiced, when competence becomes theoretical rather than embodied. For example, a midwife knows a patient needs space for prayer but ignores it due to time pressure or habit. Knowledge without practice is not competence. To consolidate: intentionality, diversity, learning, supported by awareness, knowledge, skills, encounters, desire. When combined, these produce culturally competent practitioner equals higher quality of care equals better outcomes. Cultural competence is not a destination, but an ongoing process. It requires humility, curiosity, and a willingness to modify practice in real time. Midwifery sits at the intersection of evidence and humanity, and culturally competent care strengthens both. Thank you for your attention.